Good morning. So again, I'll say up front because time is running short, we're running over, but this will be my fourth lecture. Again, I want to thank you all so much for inviting me and having me here. This is a wonderful experience. I do need to leave after this talk, but I'm very happy to take any email questions, concerns, patient issues, whatever. I didn't put in a slide, but it's kevin.ess@vanderbilt.edu. I'm sure Dr. Khalid will forward to you if necessary as well. So I'm going to briefly talk about seizure types because I can't talk about epilepsy treatments unless we're on the same page about what we're treating. And I did talk about this more extensively last year. And then I'll give you the 2018 treatment options for epilepsy, which includes mainly medical, but also some surgical approaches that we can do, as well as some other therapies that I'll mention as well. So this is a standard slide for me that we have billions of neurons that each make thousands of connections to each other, so trillions of connections, and we think epilepsy fundamentally is a disease of aberrant connections and brain communication. So therefore, problems happen. One should wonder, why don't all of us have seizures? Because the brain is so wired complex. And then this color-coded picture is how neurologists think about diseases, is where is it coming from? Is it from the left side, the right, the frontal lobe, the parietal? And epilepsy is a great example of this differential, of this localization technique. Because if we know where something in the brain is coming from, then we're much better at figuring out what are the causes and actually what are the treatments too. And the reason for that, seizures have different types, and having a proper classification will lead to the best possible treatment. So the quick, simple definition of epilepsy, and again, this is not neonatal, as I talked about yesterday, this is general, but it's 2 or more unprovoked seizures. So febrile seizures, which pediatricians deal with every day, are provoked, so don't count. So these are epilepsy seizures for other reasons, we call that epilepsy. And this is a practical definition. If you've had one seizure, only about half of those children will go on to have a second seizure. It depends on the why, of course. If you've had 2 seizures unprovoked, the odds of having number 3 about 80%. And if you've had 3 seizures, the odds of having number 4 are close to 90%. So the more seizures a child has, the more likely they'll have more. But the practical guidelines are, for most practitioners, 2 seizures is enough risk that you should then be on a medicine likely to prevent further seizures. So that's just general guideline. And the classification system really comes down to generalize, is it coming from all over the brain at the same time? This is partly an EEG diagnosis. I'll show you one EEG today. Or is it a partial or focal seizures coming from one part of the brain? And these are actually the most common type of seizures. And the simple and complex nomenclature really just means, is the mentation, the mental status altered? If you're confused with a seizure, which most people are, that's a complex partial seizure. If your seizure is simple, it means your mental status is normal, and that's unusual. So these 2 buckets I like to think about, is it partial or generalized, because different medications come into play. And if you're wrong on this, sometimes you make seizures work and or you may not help your patient. So 2 buckets is not too bad to figure out. Here's the only EEG I'll show you, and probably the only EEG most pediatricians need to know about. This is the typical generalized seizure of absence childhood epilepsy, and this is normal, and this is a discharge. This is a so-called 3 Hertz spike and wave, and I tell our trainees and general practitioners, if you ever see an EEG on any test, just look for absence because that's what they're trying to make sure you understand. This is the staring spell, this is a typical generalized seizure. And when we see this, it's very easy to make the diagnosis and know what medications should be used and also what medications to not use. So again, childhood age, I think most pediatricians know this very well, the staring spells. Most patients actually outgrow this syndrome, and that's very helpful as a doctor to be able to tell your family not only this is what we're going to do, but accurately, this is what the future looks like without being absolute. So this is a nice one to have if you had to pick a type of epilepsy, because most patients, again, are fairly normal humans. They grow out of it. They do pretty well if you treat it. If you don't treat it effectively, then they're going to have so many staring spells of their life, they may do really poorly in school and other problems. A generalized example, another generalized example, is what most people know as a generalized tonic-clonic seizure, also known as the French as grand mal, also known in Tennessee as the big one. So these are very impressive, scary seizures that can be medical emergencies if they go on too long, more than 5 minutes. I'm just giving you a couple examples of different types of seizures for launching the treatments. JME, or juvenile myoclonic epilepsy, again, is an example of the generalized bucket of seizures, and it has these different types. It has a name, myoclonic, because they have these jerks, generalized tonic-clonic seizures, as well as the staring absence. This is interesting to know about because if you have this condition, and we can tell by the EEG looks different, that you can tell the family pretty accurately, you should have your child under very good control, but they will probably never grow out of it. So again, being able to predict accurately and when to come off of medicine or even to try is helpful if you know the syndrome. This is actually pretty common if you don't know about it, but JME is something we see quite a bit. It's probably a genetic condition. And then the drugs of choice is usually valproic acid or levetiracetam, both of which are available in Jordan. Now the other bucket again is the focal seizures, one part of the brain. We always ask the question, what's wrong with part of your brain? Why are you having seizures? The generalized seizures are almost synonymous with genetic seizures because it involves your whole brain. There's something wrong with your whole brain, and it's usually genetic. We're not just now figuring out what those genes are, but a partial or focal seizure can be a structural problem. It could be a stroke, it could be a bleed. So these are the patients with the focal seizures who do deserve brain imaging for the most part. One exception is this condition called benign Rolandic epilepsy. It's actually a pretty good name, or benign epilepsy with central temporal spikes. Also a good name because it tells you it's benign, you grow out of it, and the Rolandic or central temporal region tells you where the seizures come from. This is based on a typical presentation of usually nocturnal seizures in young children, and the EEG is critical here for diagnosis because it can tell you a certain pattern. It's again, with some confidence, you can say, as a provider, your child probably has this condition, we'll treat it, but you'll likely grow out of it by this age. And it's a mistake to have patients on medicine for too many years if they have this condition because they've probably grown out of it. So again, just knowing what types you have, just some simple categories, can provide a lot of structure for the future of your patient's life. Okay, so strategies. This is things you already know about. Why treat? But seizures are bad, especially long seizures. There's something called SUDEP, which is sudden death in epilepsy, which is actually pretty rare, especially in children. But some of our patients just die, usually at night when they're sleeping. It's not well understood, but we think treating excuse me, with medicines will decrease the risk of death. But it's more for the seizure control and the quality of life. The seizures are interrupting. The child could have very prominent social concerns as well as medical issues. So most people want to treat their seizures. I don't have to argue with parents too much about treating for seizures. There are many different drugs now, but of course, first principles, you pick the drug based on the patient's needs medically, but you also have to take consideration, as do we, about how are they going to get it? Can they take it in a liquid form, a pill form? Can they afford it? Some drugs are just crazy expensive in the United States now, even though they're generic. What are the side effects? So every drug needs to be tailored to the patient's syndrome, their needs and everything, and our job is to help pick the most effective, lowest side effect approach. So I'm going to go through a list of drugs, some which you have in Georgia and some we don't. Just tell you my version of what's good about them and what's bad about them. Again, people want these slides. I think we're actually going to post them on the webpage later too, so you can get some of the details if I go too fast. Levetiracetam, also known as Keppra, is our first drug because you don't have to think as much about what type of seizures you have. It treats focal and generalized. It's generally very well tolerated with minimal side effects, except it makes some kids really, really fussy and irritable. So you have to tell families that they may have behavioral changes, and it turns out paradoxine or vitamin B6 often helps prevent that for reasons we don't fully understand. So if a patient is on Keppra, most times we also put them on vitamin B6, which is very safe and cheap to help prevent the one side effect from Keppra. You have carbamazepine as Tegretol in Jordan, and we talked about this earlier. It's really only good for partial seizures. If you give patients with generalized seizures like absence, childhood absence, Tegretol, it usually will make them worse and can also make them have generalized tonic-clonic seizures. That's the main teaching point, to be careful about what type of seizure syndrome they have. We tend to use more oxcarbazepine or trileptal in the United States. It's chemically very similar and it has to have a little different profile, but essentially they're the same: carbamazepine, oxcarbazepine, partial seizures only. Topiramate is also available here too. It is good for, again, for all types of seizures. The two main side effects are language issues, harder time thinking, which can be a problem with children, and significant weight loss. So much of this drug is abused in the United States for weight loss alone. And since we're a fat country, I can see why that would happen. Ethosuximide, unfortunately, is not available in Jordan, I just learned, and it's too bad because it's an excellent drug for the absence seizures. Instead, you can use valproic acid, which I'll talk about next, but ethosuximide really will be it's an old drug, it's cheap, it'd be a good one to have in this country. Lamotrigine was talked about yesterday in terms of its risk of rash and Stevens-Johnson syndrome. That is absolutely true. In fact, of all these drugs, this is the only drug I actually worry about with rash is lamotrigine, but we've learned the hard way how to avoid it, which is to start low, go slow. So a very low dose, you tell the family, any rashes you call me, and if the patient does have a drug rash, we stop the drug right away to prevent progression to a Stevens-Johnson syndrome. So we actually have very little problem now with this drug. It's also very good for different types of seizures. In the UK and England, the general practitioners who see all patients for epilepsy, they put all the patients right away on lamotrigine because it covers all the bases. And then only if patients typically fail this medicine do they see a neurologist in England. So it's a different system, but it makes sense. So this is a good one to prescribe for many patients. Valproic acid or Depakote is very effective. We've had it for many years. We know all the side effects, so it's something I'm very comfortable using, and it works very, very well for generalized seizures. The side effects include weight gain and also hair loss and also some ovary problems for females. So I tend to avoid it in girls, but it's my drug of choice for boys with generalized seizures. And it's a very effective drug. You have clonazepam or Klonopin in Jordan, which is a benzodiazepine, of course. It works on the chloride channel. Our newer drug, which I hope you can get soon, is called clobazam, which is another type of benzodiazepine, and it has a similar mechanism, but unlike Klonopin or clonazepam, you don't have the tolerance built up to it, so you can use it chronically very effectively, and it works quite well for many types of seizures. The older medications we tend not to use still, though these are available to you, and we use them occasionally, but the phenobarbital, phenytoin, vigabatrin, and gabapentin, they all have their use still, but for most of our patients, these will be second or third line medications that we'll use. The newer medications, which are not available in Jordan yet, have been in the United States for several years. They're new, which means they're bright and shiny and people like them, but they're very expensive and they do not have the proven track record or knowledge of what rare side effects may be, but so far they've been reasonable new tools. So shifting gears for the last part of the talk, we do surgery on patients who have medically intractable seizures, meaning they've failed at least 2 well-chosen, well-dosed medications. And if you fail 2 medication, the odds of getting seizure control with a third or fourth or combination drugs is actually quite low. So if you have focal seizures coming from one area, and we can determine accurately that that part of the brain is only causing seizures and is not important for overall function, we can do a surgery. So is a surgery effective and safe? And obviously having a discussion with the family about surgery for their child's epilepsy is very scary to them. So I introduced the idea gradually, and then over time, as it becomes clear that the patient has intractable epilepsy, this may be a pathway we do. But of course, most patients do not qualify for this approach. Excuse me. So this is a patient with tuberous sclerosis. They had an abnormality in the right frontal lobe of the brain, which doesn't show up too well there. We did a lot of extra techniques to figure out, yes, seizure coming from this area, and eventually did monitoring with a neurosurgeon, and then we used electrodes on the brain, and then we did a resection. If you choose well, and that's the key point here, choosing well of your patients, many of these patients can be seizure-free after surgery. But again, it's a huge deal, it's a lot of resources, a lot of complications, a lot where things can go wrong, but sometimes this is definitely the preferred approach, is to take out the area of the brain that's only causing seizures and only causing problems to this child. Another surgical approach, which is probably crude in the future, we'll look back, but it's an implantable device that stimulates the vagus nerve in the neck. So it's called the VNS, or vagal nerve stimulator. Somehow the stimulation of this nerve goes up to the brain and over time prevents seizures. We don't actually understand well, but there's been good studies done, and it seems to be as effective as any other drug, but the advantage is it's not a drug, it won't cause side effects, it won't interact with other drugs. So it can be a useful approach to patients who are intractable medically and who are not a candidate for this type of surgery. So it has its role, and I think over time we'll get better and better about implanting devices into brains to prevent seizures or other issues. And it's relatively expensive, but expense is a relative term compared to the expense of coming to the ER, frequently being hospitalized, all the medication, so it definitely has its role. This is something that I don't think you have. I've asked. This is a big deal in the United States. Marijuana, if you take out the part called CBD, cannabinoid oil, this is the part of marijuana that does not get you high. It's not the drug part, that's THC. There's actually very good animal data and now clinical data that's been published in the New England Journal of Medicine that this CBD product from the marijuana plant is very effective at preventing seizures in different patients. It's going through the official FDA approval process, but there's this huge political and all these issues that we don't know about. But if we get through that, it may have a role in the future for CBD. And I tell people I can't predict whether it's going to be approved or not. My only prediction is that if it is approved, it will be very expensive. That seems to be a safe bet with medicines as a marijuana plant. And then the last thing I'll talk to you about, and I will finish my last slide, is that we do diet therapy too. And this can be very attractive to certain patients. They think the diet therapy is natural. It's really not natural, but it's not a medicine, and it's a different approach. And mechanistically, it's a different way of treating epilepsy. So it can be used with medicines to get better seizure control with perhaps less medication overall, therefore less side effects. And it's thought to be an ancient treatment. Before medications were developed, people found that fasting could be an effective short-term treatment for seizures. And then in the early part of the 20th century, it was looked at as a therapy. But then in the 1980s, it became more and more looked at, and other versions of the ketogenic diet for epilepsy are popular for weight loss agents, and they're known as the Atkins diet and the South Beach diet. All of these are very low carbohydrate approaches, high fat, and if you have it with a child, you have to make sure there's enough protein so the child can grow effectively. So usually a dietitian is absolutely required to manage a ketogenic diet. It tastes terrible unless you're really motivated to do it, because if you don't have sweeteners, because it's very bland, all fat, all protein. It sounds okay at first, but we really like our sweetness, at least the Americans do. So it's a great diet, though, for babies who have bad seizures because they don't care as much about the formula. Their taste buds aren't developed. And we can very effectively treat babies with bad seizures, at least for a while, to get them through a period of time when their brain is really developing. And preventing the seizures during that first and second year of life is huge for overall brain development. Ultimately, on the ketogenic diet, all patients start to refuse to eat the diet because it's too much. It's like eating just all fat all the time. And if you're really, really motivated, you can do it, but it's hard to do. We don't understand how it works, but it seems to work differently than medication. So it's kind of something that's helpful to put on. There's very well-established protocols of how you put patients on these medications and how you avoid carbohydrates. And because these diets, these faddish weight loss diets, are pretty popular now, there's a lot of information online. So we put teenagers who don't want to do the ketogenic diet but need better control, we'll put them on the Atkins or South Beach diet, and that's actually been pretty effective for their seizure control. And people like it because it's natural. And I don't think it's natural, but again, it's a tool we have, and for the right patient, it can be very effective. And I believe that's it. So shukran lak, thank you again very much for my time here.